on the one hand, because these employers are really looking to um, get better healthcare, get better outcomes for their employees. And on the other hand, we work with high quality providers such as the Meadows, which we're honored to be on the panel with here today. And then Carrum Health is really that glue in the middle. We are, the value-based payer. We make these value-based arrangements. Um, we have a team of licensed clinical social workers that will intake patients, right? Employees and dependents of these employers. There's dedicated phone lines. We support all levels of care, and we then quickly determine, where do they live? What's the issue that is going on? And then connect them with high quality and high value providers such as the Meadow. And so you can really think about the care model as one that allows you to, get access to more commercial patients and, Carrum is a vehicle to work up patients and really get them to you, and at the same time allowing you then the flexibility to deliver the care in the best way that you see fit, without being a typical payer that calls you every day about, can you discharge the patient yet? And I want to talk a little bit more about how we do this under the hood. Next slide, please. So this, for us, it really starts with quality, right? The idea is that we find the best providers for substance use disorder treatment, and then employers will then allow us to do all these things in terms of using value-based payments, not having to, call you every day about when you can discharge a patient, and really giving you the freedom to practice in a way that you figured out works best for you. But it all starts with quality. And so when a center wants to join the Carrum Health Network, we put them through a quality evaluation process. We ask for a lot of data. We gather a lot of information. We have a lot of conversations to really assess the quality of the provider. Now, the good news is, one of the reasons we're so proud to be on the panel with Vista today is that Vista Research actually, when Vista Research works with providers, a lot of the data elements that you see here that we are looking for, Vista already has and collects, and there's an easy way, which we'll talk about, how Vista can help you get the information in such a fashion that you can easily send them to Carrum Health for our approval process. Next slide, please. And so, what do I really mean when I say we are a different payer to work with? For one, we really mean it when we say that the COEs, the centers of excellence, the providers, you define your clinical program, right? We're not coming in here telling you how to do substance use disorder treatment. That's not our role. Our role is to find providers that have great outcomes, that are really successful in treating patients, because we know you figured out a secret sauce. We don't need to know what the secret sauce is. We just need to know that it works. And in our model, we then let you apply your secret sauce in the way that best suits you and the way that works for you, right? So you really define your clinical program. We then structure with you bundles around your clinical program, right? Typically aligned with the standard ASM levels of care, right? There's going to be, a residential aspect to it. There's going to be, less than residential, like a partial hospitalization or intensive outpatient. But really, what happens within those episodes of care, how long they are, what you do with the patients, that's really up to you. We are not here to micromanage this. We're not here to tell you, how many days you can keep the patient, how many physician interactions they can or cannot have, what you do, and how you do all the follow-ups. It's really all up to you, right? What matters for us is having these great outcomes. We structure the bundle around your programs, and then you're good to go. We offer to engage across all levels of care, right? So from detox all the way through outpatient and virtual outpatient, but it's really up to you, right? If you're a program that is really focused on non-residential treatment, that works for care. If you're a program that really specializes in residential treatment and then the step downs happen somewhere else, that works for us too, right? It's really about your program and bringing your program into our network. The
That's
part of the quote unquote contract we have with the providers is also providers then also take on risk, right? Providers get the freedom to deliver care in the way they best see fit, and providers that come into our network, they then also take risk for patient outcomes, right? You're saying, well, I'm really good. I have a very low relapse rate with patients, and in our model, providers then take responsibility for that, right? Well, you say, well, if a patient has to come back, that is on us. And of course, we set the pricing with you to account for that, right? You're not here to lose your shirt. You're here to deliver great care. And we know in substance use, there's nobody on earth who can treat every patient and they're healed, right? It's a journey. It's a long process. It takes time. We get all of this. And so we structure our program around that to really reflect that reality. And what providers get in exchange from Carrum Health, one is the strong patient steerage, right? We work with all these employers. We have millions of lives, and we will then take in the patients. We'll do all the marketing. We get them engaged. We then take in the patient and refer them over to you, right? So you will get patients fully prepped and ready to go. And on the back end, because we use these bundled payment arrangements, the payment is simplified. There's no haggling over claims. If residential episode happened, you get paid the rate for the residential episode, no questions asked. And next slide, please. Oh, sorry about that. Never mind. Previous slide, please.
sounds pretty good so far, Christoph. I'm sure there's a lot of folks out there that are liking what they hear about not having to cover all the levels in a system of care. And you've got the ability to um, um, bring what you have and have that secret sauce. Now, I've had a couple of questions come in, and one of them came in early, which says, how do you become a Carrum COE, a Center of Excellence? And then there's one that's also in the details. So I'm going to start with we kind of covered the COE. Could you spend just a couple of minutes walking through the ABCs of how you become a Center of Excellence for Carrum?
Yeah, Chuck, thank you so much. Yeah, very good question. It's a pretty straightforward process, right? So you reach out to us and we'll have contact information coming at the end of the presentation. You reach out to us, and then there's really three things we'll have to do. One is we'll have to look at your quality. And as I mentioned, and Vista will talk about this, if you're working with Vista, there's an easy button to do that, to get the information to us. Two, we'll have to a contract with each other. We have a value-based payment contract that we'll go through. And then three, we'll have to really align on what the episodes of care look like for you. How does your clinical program work? And how do we match up the bundles to represent that program accordingly?
Excellent. Thank you. And I like the Center of Excellence because it allows me to introduce Shannie Smith at Meadows, who's next. And I'm going to date myself a little bit here because when I think of what Meadows has done and their early adoption of analytics and data research to drive their performance improvement, it reminds me of the song of "We Were Country When Country Wasn't Cool." Shannie has had a lot of experience leading the growth and business development for Meadows. And Shannie, can you tell us a little bit about how you got involved in value-based care, maybe a little bit about how you got involved in Vista and how that led you to the folks at Carrum?
Sure, I'd love to, Chuck. Thank you for the introduction. And I just want to say how honored I am to be part of this webinar with Christoph and Joanna, because it really is such an important topic that we're talking about today on how we really transform SUD treatment with value-based care. And Chuck, maybe if you can move to the next slide, give me some talking points to answer your question. How we got started with this is really, the Meadows has been around for over 45 years. We're known for our clinical expertise and really being a leader in treating SUD, complex mental health, process addictions, eating disorder. And we knew that our clinical model really worked. I mean, we saw the lives that we were transforming. What we lacked was really having that concrete data to show. And so we started down the path about 3 years ago, and meeting Joanna and her team and creating a partnership together, because we really wanted to invest in measurement-based outcomes. And really, there were three main reasons why we wanted to do that. We wanted to do it because we wanted to use the data to really help us improve our quality of care and have it as real-time data to inform how we were treating our patients. And so Vista really allowed us to have that capability by having these patient surveys weekly during treatment. Really allows us to be able to understand where the patient's at, be able to tweak that treatment plan, and really just improve the quality of treatment that we're providing patients. And then the second thing, I think Chuck alluded to it, is just how vast the benchmarking data that Vista has. We wanted to understand, how do we compare to others in the market? Are we better? If we're not, how do we improve? And then we wanted to take it a step further to say, how are our other facilities comparing to each other? Are there some facilities that we have that may be more efficacious than others? So really just having that insight into the data to be able to see where there are opportunities for us to improve our quality of care. And then the last piece was really being able to demonstrate how effective our outcomes are, and being able to track a patient not just 1 month out, 6 months out, but a year out of treatment, to really show that, yes, our clinical model is providing, long-term recovery. And so with that, being able to have that data, we were able to take it to Carrum Health and partner with them. We created a partnership a little over a year ago. And, that partnership, to Christoph's point, is really a risk-sharing model. We have skin in the game, they have skin in the game, which really is a perfect balance, because we're all doing something that is going to benefit the patient at the end and really drive outcomes. It's about delivering high-quality care, getting the outcomes for the patients that can ultimately reduce readmission rates, reduce the total cost of care. And it's just been such a breath of fresh air to work with a payer that gets it. And do you mind going to the next slide, Chuck? Because this is really the differentiator in working with Carrum. It's being able to be empowered as a provider to provide treatment that's most appropriate for that patient. And whether and what it allows us to do too is it really allows us to stay true to the integrity of our clinical model, and not having to cut days because an insurance company won't pay for those days because they're not being authorized. So we get to do Family Week, which we think is really, really important. We get to do deep trauma work, which is key to our clinical model. So we get to do all of these things because of this arrangement with Carrum, to be able to provide real quality care to get the outcomes that we're all looking for. And another, differentiator is that Christoph spoke to, is that they support the whole continuum of care. So if somebody comes in for acute stabilization, they can step down to residential treatment. If they need to step down to PHP or IOP, that is all supported by these bundled payments. And then, it's been such a seamless integration in working with Carrum. They have a phenomenal team. Where we've built an integration between both parties that really provides such an amazing patient experience, because they're such an advocate for the patient. They get the patient immediately over to care, so they're not having to wait. They remove all barriers to care. There's such amazing coordination between both organizations on whether it's, getting travel coordinated, or if it's the discharge planning. Like we're working so closely together that it really just provides such great patient support. And then the next slide, I wanted to just give you an idea of some of the data that we receive from Vista. If you could go to the next slide, Chuck, please. So Vista, there's a ton of other measurements, but for the sake of time, I didn't include them all. But this will give you just an idea of some of the measurement-based outcomes that we do receive from Vista. We have patient satisfaction. Our patient satisfaction, we measure patients through the surveys, and it's either very satisfied, somewhat satisfied, to be in this bucket, and we have a 91% satisfaction rate, which we're really proud of. Our readmittance rate is 2%, and this is readmittance back to actual Meadows behavioral health care facilities within a 90-day period upon discharge. And this measurement is strictly just on our inpatient for the sake of today. The next slide will show you our measurement-based outcomes when it comes to our average length of stay. You can see that our average is 45 days. And we have about 89% that have completed treatment successfully. And then we also ask patients, how they feel about individual therapy versus group therapy and what they find helpful. And we, 97% reported that they found individual therapy very helpful, somewhat helpful, or extremely helpful. And then 94% for group therapy. Next slide. And this is I believe the last slide for me, but this really gets to what we were really searching for, is to really be able to show results a year out. And you can see that we've sustained that 91% from when they, 1 month post-treatment all the way out to a year. Now keep in mind, this is just for those people that Vista, they were able to reach, but I will say they have a very high reachable rate. And those people that they actually pick up the phone or they complete the survey. So, we're also really proud of these results, and I think it just speaks to the quality of care and the outcomes of our program. So with that, I will go ahead and turn it over to Joanna so she can share more about Vista, or to you, Chuck.
Oh no, what the heck? Go ahead, Joanna, because what we're going to talk about is outcomes. We've had a couple of questions come in. We'll circle back on some process questions a little bit later. But we did have a question, Joanna, about someone wanted to know, or they're using another survey tool, and I'm not sure if they've outsourced it or internal, but they say it's hard to get the clients to complete them while they're in treatment, let alone afterwards. And so with that being said, outcomes are important, and your outcomes look great at Meadows, but it's the process that makes a difference. And so with that, I'd like to introduce the founder and CEO of Vista Research, Joanna Conti, who has her own unique professional career that led her to this. And maybe you could share a little bit about that. And then let's talk about the process of working with Vista, what we do it, how we do it, and how it impacts the Center of Excellence program with Carrum Health. Joanna?
Super. Thank you so much, Chuck. And thank you, Shannie. Can we move to the next slide? So I started Vista about 10 years ago. As most of you know, I had a daughter who developed a really serious alcoholism, and I wanted to find treatment where we could prove that, that the treatment was effective. And back in 2015, there were only 5 treatment centers in the entire US who were tracking how effective their treatment was by reaching out to their patients afterwards and learning, are they feeling better? If they're in addiction treatment, are they using, or have they remained in recovery? And so that was the impetus for me to start Vista Research Group. And we really provide 3 different types of research services to our clients. So next slide, please. The first is that we monitor patients throughout the time they're in treatment, and we report the results in real time to the clinician so they can identify the patients whose depression symptoms have just spiked up, who are suddenly having suicidal thoughts and some intention to act upon them. We start by screening the patients for a variety of different co-occurring disorders and then taking them to full academically validated assessments for any disorders that they appear to be struggling with. We also get a lot of information at the start of treatment about what brought them to treatment, what's their primary drug of choice, what are they using, how are they using, how long have they been using problematically. We get information about different quality of life metrics. Where are they living? Are they working? How are they getting along with their family members? How's their health? What run-ins with the criminal justice system have they had? That sort of thing. And then all of that goes into the information that we report back to our clinicians after every survey or at the start of treatment for them to help prepare their biopsychosocial and treatment plannings. One of the other things that's unusual about Vista is that we ask a lot of open-ended questions through our surveys, and our clinical users tell us they often feel like they get a very different type of information from the comments that patients make, because particularly today, there's just a lot of people who are far more comfortable talking to the anonymous internet than they are face-to-face. And anything that the patients tell us, we'll immediately report back to you. So next slide talks about the second component of Vista, and that is our data analytics. We're collecting a tremendous amount of patient information. We report it back to you in a data analytics platform that lets you look at 65 different metrics, things like what is the improvement between intake and their last treatment episode in the percentage of patients who have moderate to severe depression or anxiety. What percentage of patients are leaving after successfully completing all treatment versus leaving AMA? How satisfied are your patients? All of our metrics allow you to look at these different 65 different metrics. You can look at them by level of care or location. You can look at them by clinician. You can look at them by payer even. You can also look down and drill down by primary drug of choice or addiction severity or discharge reason. We give these to you so that you can really drill down into your data and understand what you're doing well and what are some opportunities for improvement. Next slide, please. The third thing we do is, as Shannie mentioned, we follow up with the patients 1, 6, and 12 months post-treatment. We will follow up with the patients 10 to 15 times at each of those time periods. We reach out by text, by email, by phone. If we don't reach the patient within the first week, we'll pick up the phone and start calling locator people like their mom or their spouse that the patient's given us permission to contact in case their cell phone number has changed. So we are typically able to reach 45 to 60% of the patients at each of those time periods, which is, I believe, very unusual. But we work really hard to do so. And what our data has shown, having followed up with 23,000 patients to date, 1 year post-treatment, what we found is about 36% of those patients are reachable and will tell us that they have not used drugs or alcohol in at least the last 30 days. And that's what we consider the most important metric of success. That if they relapsed at 6 months, that's unfortunately part of what addiction is all about, the chronic disease of addiction. But if they've been able to regain active sobriety by 1 year post-treatment, we consider that very successful. Next slide, please. Oh, even though our average is 36% of the patients reachable and reporting being abstinent for at least the last 30 days at 1 year post-treatment, we find a tremendous variation in the effectiveness of different treatment centers. As you can see on the right, at the best centers, as much as 50% of their patients are reachable and tell us that they're not using it 1 year. At the worst, it's less than 15%. Next slide, please. The fourth element of what makes Vista unique is that we want to report the data back to you in very usable fashions. So we have a number of different reports that we will prepare for you, including, an annual during treatment monitoring report and an annual post-treatment outcomes report. We also, as I'll show you in a minute, have a number of specialty reports. But what we're looking for in each of these reports is what is the data that's most important to that stakeholder. So for example, for payers, which is a top priority for most of our clients, how do they negotiate more effectively with payers? One of the things they found very helpful is this information about the reduction between the pre-treatment year and the post-treatment year in the number of ER visits, unplanned hospital stays, detox treatments, and residential PHP treatments. So remember, all of our information comes directly from the patients. This is what the patient has told us as they have changed. They maybe went to, 54% of them said they had gone to the ER at least once prior to starting treatment. In the post-treatment year, only 18% had gone at least once. And we take this the next step further. We've actually done the research to identify the cost of an SUD-related ER visit and hospital stay and detox treatment by region of the country. So we can actually calculate for you, of all the patients that we heard from at 1 year post-treatment, how much on average did your payer save in post-treatment medical spend. Next slide, please. So as I said, we package up the information we're collecting in a number of different reports for you. We have your baseline annual reports where we show you how your results track against the norms for treatment centers like yours. We look at trends over time. We look at differences by location. And we also look at differences by clinician in a special supplemental report. In addition, we've developed a couple of specialty reports. Probably our most popular is the payer summary report, where we can actually summarize the data for just members of that payer that went to your treatment center. And we summarize the information that's of most importance to payers, things like readmission rates and savings and so forth. Please go back. Another report that we've created is the prospective patient report, which is designed to showcase the metrics that are most important to families. Things like the improvement between pre and post treatment and how well people are getting along with their closest family members. And have they been more likely to go back to work or go back to school? And then finally, our newest report is going to be the Carrum Health certification report, which is going to summarize the metrics that Carrum is using to determine who would be most effective providers in their network. And so this information is at Carrum's request. We will be pulling this together for our clients and submitting it to you so that you can submit it directly to Carrum. And by the way, we don't charge extra for any of these reports. These are reports that we want you to have the data and be able to use it effectively. So last slide, please. So one of the reasons I was so excited when Christoph and I started talking again about 6 months ago about becoming involved in the Carrum project is I have been so frustrated over the years with conversations with a lot of people on this webinar and other clients about payers, deciding that patients were ready to step down or out of treatment far earlier than the providers felt that was appropriate. And our data most clearly shows that length of stay is extremely influential in terms of how likely somebody is to recover. So if you can look on the far left, you can see that 47% of patients who are in treatment for more than 90 days are reachable and report being abstinent at 1 year post-treatment, which is almost double the abstinence rate for patients who are in treatment for 20 days or less. And so we know length of stay is really crucial. And that's one of the reasons we're just so excited to work with Carrum, because it puts the power back in you, the provider's hands, to decide what treatment does this patient need, and to make sure you can do everything possible to help that patient recover.
Sounds pretty good, Joanna. Thank you. And we've got a couple of questions coming in. I'm going to re-ask a question that came in right when we were switching over to you. But one of our viewers uses the BAM surveys, the Brief Addiction Monitor. It's a good tool, but he says it's difficult to get their clients to complete them in treatment, and even harder out of treatment. So tell us a little bit about how we, as an outsourced entity, follow up and put the elbow grease into getting the information, reaching these people and getting the information back to our providers.
Okay. So as I said, we will follow up 10 to 15 times at each of those time periods. We have a whole team. That's all they do. And they are incredible on the phone. So we also will pay the patient something to take the surveys. As soon as they submit a survey or take it over the phone, they're instantly sent a Target or a Starbucks gift card. And we've recently increased the value of those because, $5 doesn't go as far today as it did 10 years ago when we started. And so also because our patients have oftentimes been responding to our texts and emails throughout the time they're in treatment, whenever it's time for them to submit a new update survey, they're used to hearing from us and they know that they're real people on the other line. They've texted us something and we've responded, and they're like, oh my gosh, I thought this was just a recording or something, and it's like, no, we're real people here, and we'll reach out to them and have some conversations with them over text during treatment. And so they're used to the idea that there's somebody at Vista that really cares about what they're doing. And so as a result of that, I think we have a very high response rate for the industry.
Thank you, Joanna. Okay, so we've had some questions that have stacked up, so I'm going to throw a couple of these out, and if you folks out there have more questions, go ahead. We've got a few minutes left for this interactive piece. This one, Christoph, there's a question. How do you handle prior authorization and case management work?
Yeah, the good news is there isn't any prior authorization in the Carrum model because we refer the patients to the provider. And because we use these bundles, we don't need to check in every day how you're doing because we have agreed on these episodic models ahead of time, and you're good to go for the entire episode of care. So there isn't really prior auth. And even in the beginning, we refer the patient to you. And so it doesn't exist in our model, I think is the simple answer. And in terms of case management, we have that team of these licensed clinical workers. They help with that coordination, right? So let's say somebody has mental health comorbidities and they need additional treatment, not just for the substance use. Let's say they finish substance use treatment, then they need other mental health treatment. We will then take on that care management duties to connect them with other options that are available to them through their healthcare benefits ecosystem.
Excellent. Okay, Shannie, you're on deck because someone has asked a question about Meadows. Do they cover adults and adolescents? And if so, has there been any friction between, I'm trying to restate this, but first of all, does Meadows and Carrum support adults and adolescents, and how's that experience been?
So I'll say the Meadows treats adults and young adults inpatient, and for outpatient, we treat 13 and up. And then Christoph, I'll let you talk about what's covered with employers.
Yeah, thanks, Shannie. Yeah, on the employer side, the current model for Carrum is to go down as low as 18. But because there is so much demand from the employers, right, they all have, they all have kids and they're asking what is available to them, or kids, teenagers. And so we are in the process of making the under 18 treatment options available throughout to our employers. There's some work that Carrum Health has to do, as you can imagine, the safeguards and the protocols and processes for working with individuals under 18 are very stringent, and so we are putting those in place before we're making it available. We anticipate making it available soon, just given the demand on the employers and given that, as Shannie just mentioned, that the centers of excellence, they treat those cases regularly, and so we are working on that, as well as looking at other adjustments we need to make to the payment model, to the clinical models. We'll be very thoughtful about this, but yeah, the demand is clearly there, and I think on the employer side, they're asking about this very frequently.
So what I'm hearing is that yes, you are a leader, and yes, this is transformative in this market, but yes, this is still evolutionary and a work in process. But you guys are fluid and willing to work to enhance this as we go along. Excellent. Joanna, this one's coming to you about the analytics. What constitutes improved quality of life, and what are those metrics?
I wonder if they're asking about Carum's requirements, or what we consider quality of life is a number of different factors. Are they living in a stable environment? How are they feeling overall? How's their, are they working or back in school? How are they getting along with their closest family members? And have they been able to avoid any more run-ins, if they had any, with the criminal justice system? So those are several of the quality of life metrics that we pay most attention to. Carrum is still finalizing the criteria that they will be using for certification and recertification purposes. So I'm not sure which quality of life metrics they're going to be using.
Yeah, that's exactly right, Joanna. And the good news is, through our close partnership with Vista Research, what we're aiming to do is, really have the vast majority, if not most, of the quality metrics and requirements aligned with the data that Vista has available, that Vista can make available to you as future COEs in that report that Joanna laid out. So we're trying to really work very closely with one another to make the quality evaluation as easier of a process as possible, right, through the support by Vista, while at the same time upholding that requirement from the employers, right? They're saying, look, if I'm really directing my employees and dependents to these COEs, I want to make sure that there is a very rigorous quality process applied. But yeah, I think in short, we're really trying to make it so that we're not going to ask for information that Vista doesn't regularly ask, because we want it to be, I know you have a lot going on. I know some centers are smaller than others. We don't want this to be a burden, right? We want this to be something that is, if you're doing great work clinically, we don't want this to stand in the way of you joining the Carrum Health.
Excellent. Thank you. However, there's been a clarification on that question, and so now we're going to go into double jeopardy. Because the person who asked about the quality of life clarified, they mentioned the recovery capital scale. Bill White's, any familiarity or referenceability to that?
I'm familiar with recovery capital, absolutely, and I'm sure we collect a lot of the same components, but we do not use the recovery capital scale itself, the exact assessment.
Yeah, and from a Carrum perspective, we are no strangers to, there may not be a fully universally agreed upon set of scales that everybody uses. on a case-by-case basis, we will look at if somebody really, they have a lot of data, but they use a different scale. We do look at this on a case-by-case basis. Are there translations available? Are there comparisons available? And so we really try to be as open as possible and work with you if you're tracking data, but you're capturing it in a slightly different format.
Thanks, Christoph. And I've got one more coming to you and then one more coming to Joanna. Someone has said, we're a very small IOP treatment center. Is this model geared towards larger centers only?
No, the size of the center doesn't matter, right? What matters to us is, are you delivering great care? Are you getting to great outcomes? And can you provide the evidence that the outcomes are great, right? Through data and otherwise. That's really all that matters to us, because we know that people have figured out, as I mentioned earlier, this secret sauce, and there's no minimum program requirement. And we really want to encourage you to approach us, right? Even if you think that, oh my gosh, I don't have a national footprint, I have one location in one city, and we're doing really great work. Please do come forward and please connect with us, because as you can imagine, especially for non-residential treatment, right? We need a lot of access points, right, for patients, and so we really are looking in many different geographies of the country. So don't think that because you don't offer all levels of care, you couldn't reach out to us. In fact, the contrary is the case.
Thank you, Christoph. Speaking of different levels of care, Joanna, I'm coming back to you with this one. Someone's asking about our results and the outcomes research. Is it for inpatient results only, or is it combined?
No, we have probably about half and half. We cover the full spectrum of care from detox through residential, PHP, IOP, outpatient. We may have a slightly higher percentage of patients that start in residential, but a lot of patients will start in PHP or IOP. We cover the entire spectrum.
Excellent. Now I've got one more question, and that is, let's talk about harm reduction versus abstinence only programs. Are the harm reduction improvements included in the follow-ups, or is abstinence only the goal for improved quality of life?
So we understand fully that there are two different ways that centers want to look at outcomes. We have spent the last 4 years developing a comparable outcomes research for medication-assisted treatment centers that oftentimes follow a harm reduction model. And so whether you are in a regular software or are in our medication-assisted treatment software, you have the option to choose how you will measure the success of your patients. Most of our existing clients have chosen abstinence as the goal, that the goal is for patients to stop using all substances. However, in other centers, particularly in the MAT world, want to measure harm reduction goals. And how we do that is we allow the patient to set their own goals. So they can tell us, I've been using opioids for 5 years. I don't want to use opioids anymore, but don't hassle me if I smoke some pot or I drink some alcohol on the weekends. I will still consider that treatment success. And so we will measure their success against the goals that they have set themselves.
Thanks, Joanna. Shannie, you have a fan out there, by the way, and when it comes to the your outcomes, they're really impressed. They're just curious from your side, the inpatient versus combined. They were just curious if those post-treatment outcomes included your outpatient program and your inpatient program combined, or do you have those separated out on your metrics?
So what I showed on the slide was combined inpatient and outpatient, but we certainly have it separated out as well. So Vista provides us they kind of slice the data in various ways, but what I showed for the slide today was both combined inpatient and outpatient.
Excellent. Thanks, Shannie. We've got a payer question where someone has asked, is Carrum connected to commercial payers like Anthem or United? And how can members of those payers get services from Carrum's providers?
Yeah, that's a wonderful question. I'll have to explain a bit, right? We work with what is called self-insured employers. So most large employers in the country, generally employers with more than 1,000 employees, they're what is called self-insured. The employee still feels to the employees like they have insurance. They get a card that'll say Anthem or United or some other insurance carrier, but under the hood, it isn't actually insurance. The employer self-insured, they just hired that company that also happens to be an insurance company to do the paperwork, send you the ID card, staff a call center, maintain a provider network. But these employers actually pay the provider bills directly. There's a bank account that the insurance companies draw from every month to pay the provider, but the risk sits with the employer. And this allows the employers a lot of flexibility. They can now go in and say, well, yes, we have Anthem or United, but for substance use disorder, we now want to use the Carrum Health network. And Carrum Health then will take the money, get the money from the employer, and we will then pay the provider with that money. We work very similar to the way one of these traditional carriers works, except we believe we have a more advantageous payment model with regards to the providers. And so, as long as the employer is self-insured, which again, virtually all employers with more than 1,000 employees are self-insured. There's 100 million individuals in the country that receive, that have coverage through the self-insured model. The employer uses Carrum, and Carrum acts as the payer. And so, but yes, in the background, of course, there's some connectivity, and we are friendly with these payers. There's a lot of data synchronization that, of course, happens in the background, and Carrum takes care of all of that for the employer.
Thanks, Christoph. And you're getting popular here because I've got another question that says, do you have a relapse prevention program?
Yeah, it's a great question. The general Carrum philosophy is that we don't want to get really in the middle of the relationship that the provider has with the patient, right? We believe that by setting up the payment model right, we want to incentivize the providers to do the right thing. So, for example, relapse prevention is obviously important, right? If you as a provider on the Carrum model, if you take on risk for things like relapse and the patient coming back for same or higher level of care, then there's a very strong incentive for you as the provider to invest into relapse prevention. And because we use these bundled payments, they'll obviously work with you on what the right price is for those, but you don't have to worry about, oh my gosh, if I spend extra time with the patient on relapse prevention, how am I going to get paid for this? Well, in the Carrum Health model, we talk about this ahead of time, you budget, you put the bundle together, you figure out the price, and you include things like relapse prevention, right? Maybe additional time you spend with certain patients, maybe you keep them a day or two longer, and really, it's really on the provider, and you have the flexibility and the financial resources to do that, because we are big believers in providers know how to do the right thing. It's really, we really want you to do all of these things, and the best thing we can do as a payer is set up the right payment model and then get out of the way and let you do your thing.
Excellent. Thank you. So I've got one last question, and I think it'll lead us into how do we handle next steps? Actually, two questions have come in, so we're going to answer those very quickly. The first one is, the last one is, have you marketed this to EPAs and unions, et cetera?
Yep, we work with all employers of all sorts of all shapes and sizes. We have union employers, or like Taft-Hartley plans, I think is a technical term. We have large private sector employers, the big brand names that you're familiar in your daily life that you encounter. I guarantee you interacted with the Carrum Health customer today, as well as large public sector employers like state governments, local government, school districts, etc. And then EAPs, yes, as well. We have very close integrations with, especially for substance use, with all the behavioral health solutions an employer might use. Right? They might have a Lyra or Spring as an EAP type solution. We of course integrate it so that if they learn of a member talking about a substance use problem, they then know how to warm transfer that patient to the Carrum Health intake. Or also, if there's like, there's other behavioral health solutions like a Magellan or like a Curalink or things like that. We integrate with all of them so that, I always tell people we have one shot with a patient and that struggles with substance use. We have to get this right. And wherever they decide to come forward, the arrows then need to point to the Carrum Health program so that we can do the transfer to the COE.
Thanks, Christoph. Last question, and then we're going to go to what our next steps are. Sorry, I came in late. How do you assess quality for program eligibility? So if you kind of recap that for us, we'll end the session with that.
Yeah, so just very briefly, like quality is very important to us. There are, very stringent quality criteria that our COEs will have to meet. There's a range of qualitative and quantitative elements that we look at in that quality evaluation. We have partnered with Vista Research Group, so providers that use Vista Research Group. We're working with Vista, in fact, right now on Vista is building a special report that Vista customers can use that allows you to meet most of the requirements of what we're looking for from a quality perspective. There's a couple of follow-ups that we might still do, but you can basically forward this to us, and it captures the vast majority of the criteria that we're looking for.
Excellent. Thank you, Christoph. And now, as we come to the end of our session, I hope you guys have found this informative and interesting. And if you are interested, we have ways to reach out to either Kathy and Alex at Carrum Health or to Joanna at Vista Research. And we'll talk about how we can align bundles that'll match your clinical pathways, review the quality data, and work on the dollars. So with that being said, thanks everyone for your time and your consideration. Any comments, questions, or next steps, you know what to do with any other thing, please reach out. Love to talk to you. And thanks again. And I wish everyone a good day. Bye.